Hello everyone, it's time for another warm-up. Let's get going. What regulates the progression of the cell cycle from the G1 phase to the S phase? Well, there are two tumor suppressors that regulate this. It's the P53 and the RB. Next, which arachidonic acid product has actions that oppose that of prostacyclin? So that's going to be thromboxanes. Remember that prostacyclin decreases platelet aggregation and vascular tone, and thromboxane is prothrombotic. It increases platelet aggregation and vascular tone. Next, in what disorder is there an abnormal breakdown of elastin? So that's going to be alpha-1 antitrypsin deficiency, where you have excessive breakdown of elastin in the lung, and that leads to emphysema. Remember, if you have a question about emphysema in maybe a very young patient or in a non-smoker, think about alpha-1 antitrypsin deficiency. All right, that's it for the warm-up. Let's get to the lecture now.
In this video, we're going to talk about different types of vascular events that can take place in the brain. Specifically, we're talking about intracranial aneurysms, which can rupture and cause a subarachnoid hemorrhage, epidural hematomas, subdural hematomas, parenchymal brain hemorrhages, which we sometimes call hemorrhagic strokes, and then occlusion of vessels by thrombosis and emboli, which we call ischemic strokes. So let's start with intracranial aneurysms. An aneurysm is a focal dilation of a blood vessel, usually due to a focal area of weakness in the arterial wall. Aneurysms can form in the thoracic aorta or in the abdominal aorta, but here we're talking about aneurysms in the arteries of the brain, in the circle of Willis. And we call these berry aneurysms because they look like a little berry growing on a vine. Or sometimes we call them saccular aneurysms because they look like they're a little sac. Now, you can find them anywhere in the brain, but usually they're going to arise at a point where two vessels branch or bifurcate. The most common location is the anterior communicating artery. Now over here on the right, you see an angiogram of this huge aneurysm in the anterior communicating artery. Then over on the left, you see a CT of the brain, and this big white density in the middle is the aneurysm that's full of contrast. Now most aneurysms typically aren't problematic unless they get really big and start compressing things, or you might have some stasis of blood inside the aneurysm which could clot and then embolize. But the most common and the most dangerous complication is that these aneurysms can spontaneously rupture, which is a dramatic, acute event for a couple of reasons. First of all, you're interrupting the blood flow, and that means everything distal to the aneurysmal bleed is going to be getting less blood. And then second, the blood itself is very irritating to the brain, and it's going to go into the CSF and irritate lots of different things and cause a really bad headache. And so one of the hallmarks of a ruptured berry aneurysm is that the patient says, "I have the worst headache of my life." So, what kinds of things increase your risk of developing intracranial aneurysms? Well, they typically begin at birth as a small defect in the artery, a little weak spot in the muscularis. And then over time, that little arterial defect just gets worse and worse and worse. And high blood pressure will cause that aneurysm to sort of balloon out even more. So the risk factors for aneurysms are things that create defects in the arteries and things that cause high blood pressure. Autosomal dominant polycystic kidney disease is a classic risk factor. These patients form cysts in their kidneys, and they also can form these saccular aneurysms in the brain. We've mentioned that Ehlers-Danlos syndrome can increase the risk of berry aneurysms because collagen defects that weaken the walls of the arteries. Now, you may also see Marfan syndrome sometimes listed as a risk factor in certain sources, but that's probably not true. Then other risk factors include hypertension, smoking, advanced age. Again, the longer you go on with this defect, the more likely this aneurysm is to balloon out. And then race is another risk factor. These are more common in black patients. If a berry aneurysm ruptures, that causes a subarachnoid hemorrhage. Now for step one, you need to be able to differentiate the common causes and presentations of epidural hemorrhages versus subdural hemorrhages versus subarachnoid hemorrhages. The most common cause of a subarachnoid hemorrhage is a ruptured aneurysm. And the second most common cause of a subarachnoid hemorrhage is a ruptured arteriovenous malformation, or AVM. Then other causes include trauma, bleeding disorders, sickle cell disease, and so on. But 80 to 85% of subarachnoid hemorrhages are due to ruptured aneurysms. So what is a subarachnoid hemorrhage? Well, it's where you have blood in the subarachnoid space, where the CSF is located. And that blood is irritating and it causes headache. So again, these patients come in complaining of the worst headache of my life. Any patient who comes in complaining of the worst headache of their life needs to be worked up for a subarachnoid hemorrhage. You're going to start with a CT scan of the brain to see if there's any blood. But if you don't see any blood, you're not finished with your workup. The next thing you would do is a lumbar puncture to examine the CSF for any evidence of blood. Now, you can't put a needle into the subarachnoid space without going through the skin and going through a bunch of other tissues. And in that process, you're going to have a little bit of bleeding. So typically, when you do a lumbar puncture, you're going to collect the CSF sample in 3 or 4 different tubes so you can send them to the lab. And you're going to expect that the first tube of CSF is going to be the bloodiest. Then the second tube of CSF should have less blood, and the third or fourth tube should have essentially no blood at all. So if you see blood in the last tube of CSF, you're going to think about a subarachnoid hemorrhage. You expect some blood in that first tube, but not in the third or fourth tubes. But sometimes patients don't come in right away. They might try to treat this awful headache on their own for a few days before they come to see you. And in that case, you might not see any blood cells in the CSF. But what you could see is that the CSF is yellow. We call that xanthochromia. The CSF is basically yellow because of bilirubin. The hemoglobin in the CSF has been broken down into bilirubin. Now, the main treatment for a ruptured aneurysm is to go into the brain, find the aneurysm, and place a surgical clip so that it can't rebleed. But we also give a drug called nimodipine, because about 40% of patients with a subarachnoid hemorrhage due to this ruptured aneurysm are going to have some vasospasm in the cerebral vessels 3 or 4 days after the bleed. Now, what kind of drug would you guess nimodipine is? It's a dihydropyridine calcium channel blocker, kind of like nifedipine. Drugs that end in dipine are all dihydropyridine calcium channel blockers, and they work by dilating vessels, especially arteries. Now, it's been shown that nimodipine doesn't actually prevent this vasospasm, but it's also been shown to improve outcomes following subarachnoid hemorrhage. We don't really understand how it works, but we know that it does work. Next, let's talk about another type of intracranial bleed called an epidural hematoma. An epidural hematoma is where you've had bleeding outside the dura, between the dura and the skull. Epidural hematomas are most commonly due to a rupture of the middle meningeal artery, which runs under the temporal bone. So make sure you know that. If you have trauma to the side of your head that fractures the temporal bone, that can lacerate the middle meningeal artery. And because this is an arterial bleed, a high pressure bleed, as that epidural hematoma expands, it's going to start compressing the brain, and it can cause some herniation of the brain downward across the tentorium. And this can lead to a cranial nerve 3 palsy. So if a patient has a head injury, and then the pupil is fixed and dilated, the eye is looking down and out, that's not a good sign. And another classic clinical feature is that with an epidural hematoma, you have what's called a lucid interval, where the patient has a head injury and he may lose consciousness briefly, but then he gets up and he seems fine. He's lucid, he's oriented, he's conversant. This is called the lucid interval. And then over the next several hours, as that hematoma is expanding and compressing the brain, the patient's going to gradually become obtunded. He'll have herniation of the brain in that dilated pupil. He'll have headache and vomiting and seizures. And these patients often die unless this is recognized quickly and surgery is performed to relieve the pressure and drain the hematoma and stop the bleeding. Now, we're going to look at some pictures of an epidural hematoma in just a second, but first I want to talk about a subdural hematoma so we kind of compare and contrast. An epidural hematoma is above the dura, right? That's what epi means, above or upon. But a subdural hematoma is below the dura, like a submarine is below the surface of the water. Now, that's an important consideration when it comes to the shapes of these things on CT. So an epidural hemorrhage is between the skull and the dura, and a subdural hemorrhage is between the dura and the brain, or technically between the dura and the arachnoid. A subdural hematoma is not an arterial bleed. It's not a rapidly occurring high-pressure bleed. A subdural hematoma is usually due to a rupture of the bridging vein. It's a venous bleed, a slow bleed. Now, this tends to occur in elderly patients who have poor balance and fall and bump their heads, or in alcoholics who stumble around and bump their heads on something. And trauma can do it too, even relatively minor trauma like a whiplash injury, which is why we sometimes see subdurals in shaken baby syndrome. Now, because a subdural bleed is below the dura, there's not really anything limiting it from spreading out laterally. Again, it's a low-pressure venous bleed. This blood is just going to gradually ooze out and spread out between the dura and the arachnoid, which gives the subdural hematoma this classic crescent shape. It can accumulate and push the brain over and cause a midline shift, but I wouldn't hang my hat on that. I would just remember that the subdural hematoma can spread until the dura reflects back at the midline and forms a falx cerebri. But look at the epidural hematoma. Now, this is outside the dura, which is tough and leathery, and the dura is attached to the skull at the suture lines. So an epidural hematoma has to kind of peel the dura off the inside surface of the skull as it expands. So it forms this expanding lens shape, kind of like a biconvex lens or an ellipse. But that blood is going to be trapped by the points where the dura attaches to the skull at the sutures. And if you still can't remember that, one student came up with a mnemonic that says the hematoma that's shaped like a person's eye is an epidural. And then the hematoma that's crescent-shaped is a subdural. Or you could say the subdural snakes along outside near the skull. So whatever it takes for you to remember that, be sure you can identify each of these correctly on either a CT image or just by a verbal description. Another type of hemorrhage is an intraparenchymal hemorrhage, which is hemorrhage not in the space adjacent to the brain, but rather a hemorrhage within the brain parenchyma itself. We also call these hemorrhagic strokes. Now these are usually due to severe hypertension. For instance, if you use cocaine, the blood pressure might get so high that you have a brain hemorrhage. Other risk factors include vascular malformations, which can rupture and bleed, vasculitis, where inflammation of the vessels makes them more prone to rupture, amyloid angiopathy, where the amyloid protein is deposited in the vessel wall and that kind of weakens the wall so it can rupture, brain tumors that erode into an artery, and also don't forget iatrogenic causes like anticoagulation. Anticoagulation could lead to any of these hemorrhages, really, especially in elderly patients who are on warfarin who then bump their head and they can get little subdural hematomas. Then one last type of brain hemorrhage to discuss is an intraventricular hemorrhage in the newborn. Now this is in your study guide. Intraventricular hemorrhage is hemorrhage into the ventricular system. It's most commonly seen in preemies with very low birth weight, less than 32 weeks, less than 1,500 grams, within the first 72 hours of life. This hemorrhage originates from the germinal matrix of the subependymal subventricular zone that gives rise to neurons and glia during development. So this is a very sensitive area of development. It's growing lots of new things. This is an area that's more likely to hemorrhage in newborns. All infants born at younger than 30 to 32 weeks gestational age should be screened with an ultrasound to make sure they don't have an intraventricular hemorrhage. So intraventricular hemorrhage is definitely something to be aware of. So that's it for intracranial hemorrhages and hemorrhagic strokes. Very high yield. So before we jump into ischemic strokes, let's pause for just a second and review a couple of these. So I'm going to show you a couple of CT scans and you tell me what kind of hemorrhage we're looking at. This is a lens-shaped hematoma or an eye-shaped hematoma, and we said that's an epidural hematoma. And here's the next one. This is a crescent-shaped hematoma that's snaking along the edge of the skull, so that's a subdural hematoma. And what's going on over here? That looks like some bleeding in the brain parenchyma. And there's a lot of tissue swelling that's collapsing the ventricle and shifting the midline. So a couple of things are going on in this one. Next, we're going to discuss ischemic or thrombotic strokes. So this term stroke basically means brain ischemia, and there are two broad categories of stroke. One category is a hemorrhagic stroke, where you have intracerebral bleeding, and the brain tissue distal to that bleed isn't being perfused. Now the brain is very sensitive to ischemia. If you stop perfusing the brain, then after just 5 minutes you're going to start to have some irreversible damage. It might take 20 minutes to damage the heart, but the brain's very sensitive. It's very needy. It needs a lot of oxygen. If it doesn't get it very quickly, it's going to start dying. And the other big category of stroke is a thrombotic stroke, where you have a blood clot that occludes the vessel. That's also sometimes called a thromboembolic stroke, because you have a piece of a thrombus that breaks off and embolizes downstream in a smaller vessel. Or you'll commonly hear this called an ischemic stroke, which is a bit misleading because hemorrhagic strokes cause downstream ischemia too. But when you hear the phrase ischemic stroke, think thrombosis. So whenever a patient comes in with stroke symptoms, the first thing you get is a CT scan to look for evidence of a hemorrhagic stroke or an ischemic stroke. Now, fortunately, acute bleeding shows up very nicely on CT scan as a bright, white, hyperdense area. And this area marked with an asterisk is a huge parenchymal hemorrhage. And then the arrows are pointing out that blood has leaked into the ventricles. But you have to distinguish between a hemorrhagic stroke and ischemic stroke right away, because if it's an ischemic, thrombotic, thromboembolic stroke, you're going to treat it one way, maybe give a thrombolytic to break up the clot. But if it's a hemorrhagic stroke, you definitely don't want to give any thrombolytics or anticoagulants. So it's imperative that you know what type of stroke you're dealing with before you can treat it. Ischemic strokes are commonly caused by thrombus forming on an atherosclerotic plaque in the carotid, and then that embolizes to the brain. Or from atrial fibrillation, where the thrombus forms in the left atrium and then embolizes. Less common causes of ischemic stroke would include septic emboli from infective endocarditis, or if you had a DVT, Those would typically embolize to the lungs and cause a pulmonary embolus, unless the patient also happened to have a patent foraminal valley, which allows that embolus to bypass the pulmonary circulation and go straight from the right atrium to the left atrium and then out to the systemic circulation into the brain. Or a fat embolus from a long bone fracture or a pelvic fracture. An ischemic stroke is defined by the presence of infarction of the neural tissue. You have to have infarction. Now, if there's a transient episode of neurologic deficit due to ischemia without infarction, we call that a transient ischemic attack, or a TIA. But if there's infarction of the neural tissue, that's an acute ischemic stroke. And we used to define TIA and stroke based on the duration of the patient's symptoms. That's no longer the case. If there's tissue infarction, which we can usually see on an MRI eventually, that's going to be called an acute ischemic stroke. But when a patient shows up in the ER with acute symptoms, you can't always wait around for an MRI. You need to act quickly. So we're going to treat an acute TIA and an acute stroke in much the same way. So you might give a thrombolytic drug like TPA or streptokinase or urokinase if the patient meets all the criteria to receive thrombolytics. There are a whole bunch of very specific exclusion criteria which you don't really have to memorize for step one, but basically relatively few patients who come in with an acute stroke are actually going to be candidates for TPA. You have to pull the drug out and then you go through this checklist of like 20 different things. Do they have this? Do they have that? Are they experiencing this? And if any one of those things is present, like maybe they had surgery yesterday, then you can't give one of these drugs because the risk of complications outweighs the benefit of the drug. Thrombolytics are contraindicated in patients with active bleeding, patients with any history of intracranial bleeding, patients with recent surgery, a known bleeding diathesis like hemophilia, or severe hypertension. And again, don't worry about memorizing this list right now. But the short version is that relatively few patients who come in with an acute ischemic stroke are actually going to be candidates for TPA. But you should know that there's a definite time window for giving thrombolytics because time is brain. The longer the brain's been ischemic, the more damage is being done. So there's definitely a limited window of time in which thrombolytics can be given for an acute ischemic stroke. However, the exact duration of that time window is somewhat in flux at the moment. For years and years, the window was considered 3 hours. The patient had to come to the ER within 3 hours of the onset of symptoms. Beyond 3 hours was considered too late. But the latest data are now saying that you can go as long as 4.5 hours, and some people are even looking at 6 hours. But the bottom line is that sooner is always better for thrombolytics. Now, on your exam, I really doubt that they're going to give you a clinical scenario where the patient's in a gray area. They might give you a patient who presents with 12 hours of stroke symptoms, and you know right away that he's not a candidate for thrombolytics. But I doubt they're going to give you a patient whose symptoms started 4 or 5 hours ago and make you choose whether or not it's appropriate to give TPA. But one classic scenario that you might see is a patient who wakes up with stroke symptoms. Say he went to bed feeling fine at 10 p.m. and he wakes up at 7 a.m. with hemiparesis and facial droop or whatever. In this case, you have to assume that he had the stroke as soon as he went to bed. So it's been 9 hours and he's not a candidate for thrombolytics. Be aware of that.
And finally, what parts of the brain are most vulnerable to ischemic damage? It's the cerebellum, the neocortex, the hippocampus, and the watershed areas.
What's a watershed area? A watershed area is an area of the body that receives blood supply from the distal branches of 2 different arteries. Now in the brain, the watershed areas are between the anterior cerebral and middle cerebral arteries and between the middle cerebral and posterior cerebral arteries. So if you occlude one of these arteries with an embolus, the watershed areas are somewhat protected from ischemia because they have 2 blood supplies. But when the blood pressure drops and there's hypotension, these watershed areas are going to be the first to be affected because they're supplied by the most terminal branches of these arteries. All right, go ahead and work through the end of session quiz, then we'll go through the answers. First question. What's the most common site of a baryaneurysm, and what diseases are often associated with baryaneurysms? So the most common location of a baryaneurysm is the anterior communicating artery. And the diseases associated with them are autosomal dominant polycystic kidney disease and Ehlers-Danlos syndrome. Next, an 85-year-old man with Alzheimer's disease falls at home and presents 3 days later with severe headache and vomiting. What's the most likely diagnosis and which structures were damaged? So this is a subdural hematoma due to a rupture of a bridging vein. Now, if this was an epidural hematoma, you'd expect him to be dead or severely incapacitated. And remember, subdurals are more common in the elderly, and epidurals are more common in teens and young adults. Next, a healthy 52-year-old man presents to the ER with stroke symptoms that began 2 hours ago. what treatment should be considered immediately, and what study must be ordered immediately. Again, in any patient with stroke symptoms, you want to determine whether he's a candidate for a thrombolytic therapy like TPA. And one of the first parts of the workup is to determine whether this is a thrombotic stroke or a hemorrhagic stroke. So you need to order a CT of the head without contrast. That's one of the first things we order in a suspected stroke. Let's also run over these rapid fire facts. The worst headache of my life should make you think about a subarachnoid hemorrhage. A lucid interval following head trauma should make you think about an epidural hematoma. Bloody CSF on lumbar puncture is seen in a subarachnoid hemorrhage. The most common cause of subdural hematoma is rupture of the bridging veins. And the most common cause of epidural hematoma is rupture of the middle meningeal artery. All right, that's it for now. I'll see you next time.